with you. First, I'd like to say welcome. We're from the BC Pediatric Society. We're really fortunate that our first Journal Club presentation gets to be from the very famous Bill Abelson, Prince George. You all know him, and it's very fun to be able to present that. He has been so involved in at the national level and at the BC Pediatric Society level for so long, and has done an incredible amount of volunteer work for the profession. And as you know, the BC Pediatric Society is all about volunteering. And so, Bill, thank you so much for presenting today and sharing your wisdom with the group. We also have, I've got one more thing I just want to show you before we get started. And that is, as a reminder to folks, as a society, we do a handful of things on behalf of the members. Without you, it's not possible. We try very hard to do an incredible amount of advocacy around child and youth mental health issues and other concerns. We spend a good deal of time in our economics committee that Bill is a part of, thank you, Bill, to advocate on behalf of the proper wages for physicians, pediatricians, and we were quite successful recently with the Disparity Fund, and you've, I'm sure, seen that in the newsletter. We do education events like this, and the two-day conference, which we partnered with Neurology, is happening November 6th and 7th this year. We already have as many people signed up as the best year, which was last year. Everyone has already signed up and we're seeing it grow. So thank you. If you haven't already registered, please do. We also do a fair amount of communications in terms of newsletter, website, and Facebook, and we're working on making that a lot better. Without further ado, Bill, I would like to welcome you to our first CME post the introduction of COVID pandemic. And we'll, after your presentation is over, we'll open up for questions. And as a reminder to everyone, when you want to ask a question, you can also put it in the chat box. In that chat box is also the survey for your feedback, to give Bill feedback and the society about how this event went. And we'll put a little bit more information in there. If you would like CME credits, we'll definitely need to know whether there's more than one of you on a given link. So please type in your name in the chat box if there are more than you on your link. And if your name is wrong on your link, I won't be able to also register you. So this is a really important element for tonight, our first time doing it online this way. Bill, take it away. Welcome.
Awesome. Well, thanks very much, Brian. Very generous introduction, and it's a pleasure to be here and give this talk. I wished I was the last of the presentations pre-COVID, enjoying a nice meal at some restaurant down in Vancouver than online Zoom, but so be it. And just to, can you guys see my slides? Am I sharing them?
No.
No? Okay, that's not good. Let me try again.
Bill, as a reminder, you have to press share again once you find the document you want to open.
Okay, let's try that. Did you hand me the, Brian, have you handed me the, because it keeps on going back to the BCPS Society.
Oh, there you go.
Okay, awesome.
Yep.
Fantastic. So now can everybody see it?
I can see it, Jane can.
Yes,
Okay,
yes,
great.
we can see it.
So basically, this is Be Prepared, and the B stands for Type B. We're clearing up confusion around some of the meningitis vaccines. Just a disclosure, I have received honorariums both from GSK and Pfizer, who both make meningococcal type B vaccines. And I should note that GSK is sponsoring this talk, and I'd like to thank them for that. And so in terms of objectives, we want to describe the burden of meningococcal disease in Canada and globally, differentiate between the vaccines, and I was basically it should really have said meningococcal B vaccines, but I'll talk a bit about the others, available in BC, who should get them, and just talk about the growing body of evidence to talk about implementing their use. And I'd like to also thank GSK and Pfizer for use of slides. I'm responsible for the content that I'm presenting, but I did swipe slides from just about everywhere because I am PowerPoint challenged. Basically, in terms of meningococcal disease, it's a gram-negative diplococcus. There's a very pretty little picture of it there. And it's encapsulated bacteria, it's like H. fluenza pneumococcal. It's got a polysaccharide capsule, and that protects the bacteria against the immune system. And there are all sorts of different serogroups, but basically 5 of them cause basically most of the disease, and that's A, B, C, and then don't ask me how they ended up in Y and W135, way at the back of the alphabet, but those are the ones that cause most of the invasive disease. And the interesting thing is, basically, this is a pretty common bacteria. When it's invasive, it's obviously not a very good thing, and fortunately very uncommon. That's what it invades and either causes meningitis or septicemia, nasty illness. But it colonizes the human nasopharynx, and it only colonizes the human nasopharynx. And I was kind of thinking, hey, maybe we don't need vaccines. Maybe if we just all had sort of a eradicate meningitis day and took maybe, I don't know, a syringe of bleach and I don't know, maybe sort of squirted up our nostrils, then, sorry, it's a joke, okay, because I don't want anybody to do that. But it is interesting that it only colonized the human nasopharynx. And it's basically transmitted through close contact with infected persons and respiratory secretions or saliva. And like a lot of these, like basically viral infections. And so it's very common, and you see up to a quarter of adolescents and young adults have it in their nasopharynx. And so it's kind of shocking because you think, well, if I do a throat swab, why am I not seeing this? And I imagine some of you are surprised by this, but the bottom line is it's not being reported out or looked for because essentially it's a normal pathogen in the nasopharynx. In terms of prevalence, this is kind of a nice little chart on the right. You can see it's over a 20-year period, and it's not a straight line. It goes zigzagging up. You can see a peak there in 2001 when there was a serogroup C outbreak, and some of that was in Abbotsford, and it wasn't until 2003 that meningococcal type C vaccine was introduced in BC. And you can see that overall, over time, that nice yellow line there has gone down. What you do see is that serogroup B is more prevalent. In 2016, the quadrivalent vaccine, the ACY-W135, was introduced in BC for adolescent booster. But you can see that overall, those years, B seems to be the most prevalent. And so it's sort of, we'll talk about it because why isn't there a vaccine for this? Why isn't it covered? The other thing to note from this is that it's not a common disease. I mean, if you look, and I don't have a pointer and I don't want to try and use one because the last time I tried to use that on Zoom, it was a disaster. But you see that little serogroup B vaccine line, it's the incidence rate 0.4 per 100,000. This is not a common disease. And if you look at C now is virtually eliminated, but Some of the other vaccine groups are 0.1 per 100,000. So not a lot. And the interesting thing is basically until about sort of, I think it was 2018 or 2017, but actually W is now the most common vaccine strain in Canada at the moment. It's kind of bizarre, but that could change. And that's the thing to realize is these numbers aren't static over time. We don't totally understand why things come and go, but I mean, look at all the other things that we deal with, like influenza, RSV, they change year to year. So I'm just going back up. And you'll also see until 2017, serogroup B basically accounted for half of all the the invasive meningitis disease cases, and 80% of all of those cases in infants and young children. So by far the greatest burden is, at least more recently, has been from serogroup B. And there's another way of looking at it. The most recent data is 2011, 2015, and it's B basically. And there it is, 2018 is when serogroup W became the most prevalent IMD in Canada. So this is another very pretty little picture. And you'll look on the left and you'll see the cases. And so those are the bars in all sorts of pretty colors. And you'll see that the number of reported cases of invasive meningococcal disease in Canada seems to be, well, you'd go, there's basically under age 1, 60, and over 60, there's 120, but that's sort of not telling the story, because when you go to the right side, you'll see that the incidence is much higher in the less than 1. So that's where it starts to be fairly significant. You can say, well, it's, you know, you have more cases greater than 60, because the bottom line is we only spend 1 year less than the age of 1, or hopefully we'll spend a lot more years than that greater than 60, no guarantees, but I'm keeping my fingers crossed. And so the incidence of disease is really high in the less than 1 age group, 3 per 100,000. And you'll see when you go back to the bars on the other side, you'll see that especially in the younger age group, serogroup B counts for the majority of disease. And the other thing just to keep in mind is that even though it's very rare disease here, it's certainly worldwide quite a significant disease. And for a number of years, that meningitis belt was just horrific. And you'd have basically endemic disease, but regular epidemics of generally serogroup A, and it was horrendous. And believe me, you didn't have vaccine avoidance there. When you showed up with a meningitis vaccine, they were quite keen to take it. And interestingly, after a new MenA conjugate vaccine was introduced, W basically is the new A in Africa. So it's quite interesting that they basically I mean, I don't know the latest figures, but massive reduction in A across Africa, which is fantastic. So part of you, I'm thinking, are saying, well, why do we want to prevent this? I mean, well, obviously we want to prevent everything, but you know, why put effort into this? Because it's so rare versus a lot of other things. Definitely rare in Canada, definitely not rare worldwide. Part of the thing is most cases occur in otherwise healthy individuals. And the real reason you want to prevent it is early diagnosis is very difficult and it's a very rapid course and has quite significant morbidity and mortality. And this is the very disturbing fact of it, is that literally, you know, you wake up, or, you know, kid wakes up and, you know, has a headache and sore throat, aches, fever, doesn't want to go to school, and, you know, bitching in bed, which is not uncommon for an adolescent, certainly wasn't uncommon when I was an adolescent. Parents leave the house and, you know, come back 12 hours later after work and the kid is looking way worse, and hours later he's dead. And you've seen the figures in the previous slide, you know, fatality rate, maybe 10%, 30% of survivors have significant sequelae. Either I have a very poor memory, or maybe I'm just really bad at treating this, but my recollection of cases of meningococcal disease that I've seen, all have been really ugly. And maybe, like I say, you tend to just remember the bad ones, but the one I remember is a kid who came in from a town about an hour and a half away from here, came into emergency room there. They picked it up very quickly. They basically got him into an ambulance, got antibiotics into him, got fluids into him, got him here. By the time he got here, we were ready for him. I was there. I had an internist help me get some lines and stuff. He was a big kid. Get some central lines. I got IVs, got fluids in him, started pressors. I can't remember, dopamine, probably epinephrine, you name it. In touch with BC Children's Hospital. And I couldn't get his pressure up, no matter how much fluid, how much pressors we were using. And he got down to Children's, and he was there for about 3 days. And literally in the ICU, great care, but they just couldn't get his pressure up in 3 days, and he died. And it's a pretty horrendous thing when you've got basically a healthy kid 1 minute and in that type of story. So that's basically the reason why you want to prevent this type of disease. And it's just so awful. Basically, who's at risk? Well, we already said infants especially, but less than 5. Adolescents, because they're doing all sorts of things that we wish we were still doing at our age. And basically others with compromised immune systems, for example, asplenia. Travel, working in the lab, being in the military in crowded circumstances. These are things that adolescents do that get them into trouble with meningitis. And so just to take a step back, we want to prevent this, and it should be easy because it's encapsulated bacteria, and we got lots of vaccines against encapsulated bacteria. A lot of my younger colleagues probably don't even or haven't seen H-flu meningitis, whereas when I was, a senior resident doing infectious diseases at Sick Kids in Toronto, I'd be seeing weekly on a basis. And in 86, a PRP vaccine, so that's pyruvate phosphate, polysaccharide of the H-flu brought in. Very simple. They just took the polysaccharide capsule. It was immunogenic. They inject it. You're immune, basically. Then they got a bit clever. You see there in 1988, they have a PRPD conjugate vaccine. So in other words, the polysaccharide capsule is what you want to immunize against, but because it's polysaccharide, it's not terribly immunogenic, doesn't get T cells involved. So they smartened up and conjugated, put a little protein conjugate onto it to stimulate immunity. And you can just see how H-flu has gone down. And we don't see H-flu beat right now. I mean, we just don't see it. And then most of you, somewhat maybe not as younger than me, but you remember when pneumococcal vaccine came in. And this is an example of the incidence of the target serotypes and the initial PCV7, the Prevnar 7 were. They just dropped off the screen. In fact, probably even, do you even remember asymptomatic bacteremia? It's something that we don't see anymore. Whereas we used to see it all the time. Anytime somebody came in with a fever, we'd be thinking about it. Now you don't see it. But also what this shows you is, pneumococcal is a bit more complicated because they don't all have the same polysaccharide capsule. So now we're going to take a bit of polysaccharide from 7 different ones. We're going to conjugate it so it's immunogenic. And that's why we now have PCV13, and we're probably going to have even more, but it's a bit more complicated because they have different capsular polysaccharides. And then in terms of meningococcal disease, it's basically in the UK in 1999, they introduced a vaccine for serogroup C. And those bars are basically actual cases. So those are the observed cases in the UK in those years. And you can see in 98, 99, they had almost 1,000 cases. And you can see in 2008, 2009, they had basically down to 0 cases. So they basically eliminated it. And that's pretty impressive. And then, and now we've got all sorts of different C conjugates, well, 2, I should say, meningococcal C in BC. And then there was a quadrivalent, so that took the C, but also added A, Y, and W, and would protect against those 4 strains of meningococcal disease. And then it's sort of like, why don't we have B? And we do have B now, but B was a bit more complicated. So we've now got 2 B vaccines, and we're going to talk about what makes them different and why it took time to get them, and why we don't have an A, B, C, Y, W135. And so we've got 2 vaccines. There's 4C MenB, or MenB 4C, which is a 4-component meningococcal B vaccine. And its trade name is Bexsero. And I'm going to use the trade names for this because they really are unique products. The Bexsero is a GSK product. Then there's MenB FHBP, which stands for factor H binding protein. And it's called Trumenba. It's a Pfizer product. And what was the challenge of making these? Well, the challenge was that they have a unique polysaccharide, but the problem is it's very similar to a fetal neural cell molecule, basically. So what that means is 2 things. One is because it's closer to human than the others, it's not terribly immunogenic. And the other thing that it means is that you have a potential for an autoimmune response, and you don't tend to want to generate vaccines against something that's similar to yourself. And interestingly, for meningococcal B, they basically figured out, well, that's okay, it's polysaccharide, but they also have something called an outer membrane vesicle, or porin A. And what's neat about that is they actually have not long-standing, but they did come up with vaccines. So, but they're strain specific. And basically Cuba it was the first vaccine for MenB, and that was developed in '89. And I'm sure that most of the people in the room here have never even heard of that. Probably, unless you're from New Zealand or Australia, probably not even aware that they also had a vaccination program in 2004, 2008 against a meningococcal vaccine, and they developed their own vaccine called MenB, or I guess it was ME and NZ for New Zealand B. And these were very successful vaccines. I'm just going to show you the next slide, what happened in Cuba. And you'll see there the incidence per 100,000 was massive. So we're talking about incidence here of 0.4 per 100,000. There was 14 per 100,000. So 35 times as common. And you'll see when they put in the immunization program there, they basically simply eradicated it. So the outer membrane is very immunogenic, very effective, but it's very strain specific. And so basically, in terms of B vaccines, first one, Bexsero, was created with a unique, and I think it's interesting to go into how these vaccines were created, because as we're reading about COVID, I mean, there's so many different approaches now to making a vaccine. And so it's fascinating. I found it fascinating anyway. And so this was the first vaccine basically that was created by reverse vaccinology. I put the first in quotations there because, as I just described, it wasn't really the first vaccine against MenB, but it was the first vaccine that was designed to be against multiple strains of MenB. In other words, it could be used in a preventative fashion when you did not have an epidemic strain. And basically what they did in terms of reverse vaccinology is they basically figured out the genome. They sequenced the genome. They picked out a bunch of candidate vaccines and then figured out which might be potential vaccine candidates. They figured out which one of these proteins were surface expressed, because if it's not surface expressed on the meningococcal, you're going to have challenges both fighting it, but also they've successfully expressed an E. coli there to produce it. And you can see how they broke it down. And they basically broke it down into, they ended up with 3 candidates, and they combined that with the outer membrane vesicle from a New Zealand strain. And that's how they decided they were going to make their vaccine. And so just for your interest, the three that they sort of, the three antigens they picked by the reverse vaccinology approach were the FHBP, which is factor H binding protein. There's a Neisseria adhesin A, and Neisseria heparin binding antigen. And then, as I said, the POR A, or the outer membrane vesicle protein from the New Zealand strain. The interesting thing about that is you think, well, why did they pick that? Because that's really just a strain specific. And it's not sort of generalizable, but interestingly, outer membrane vesicle probably has almost an adjuvant properties to it as well, which makes it really interesting. And the idea was also that multiple antigens may provide synergistic killing, provide strain coverage as well. And basically Bexsero, so this was the first of the newer B vaccines, was licensed Canada in December 2013. And it is indicated at the moment for immunization of individuals from 2 months through 25 years old. And basically, just skip the top part. It's a 2+1 schedule, essentially. In other words, 1 dose, a couple months apart for infants, and then a booster dose in the second year of life. And for older people, children, adolescents, that is, 2 doses, sort of at least a month apart, and then again, a booster dose if you're continued risk of exposure. And the other thing is it can be given with routine vaccines, which of course is very important. And it is definitely immunogenic. And these are just sort of the examples of after the series completion, it's what it does. It's safe. It has initially there were some concerns because we're giving it to infants basically, and it did definitely have a higher rate of febrile reactions. And so it is given with acetaminophen, and that seems to have taken care of things. It's very well tolerated. So that's Bexsero, and we'll get back into some other data about it later. And we'll go on to the next thing, which is Trumemba. So this is MenB FHBP. And so this is odd because you said, well, one of the antigens, not strains, one of the antigens in Bexsero was factor H binding protein. What's the difference? Well, so Trumemba did it very differently. And what they did is rather than doing reverse vaccinology and figuring out the genes and creating the proteins and figuring out which might be candidates, they kind of just chopped up the meningococcal into a variety of pieces and figured out what they felt were good antigens. And so the difference is they're using FHBP, factor H binding protein, but it's a lipidated factor H binding protein. So it's not just the protein that sticks out of the membrane, it's the lipids that sort of integrate it into the membrane of the bacteria. And it turns out that there basically are two there are two basically families or subfamilies, and they've got A and B, and about a third of the strains are A and about 2/3 are B, and they picked one from each. And then what they did is they picked the A05 variant. You can see that towards the left of the A bubble, and they picked the B01, which is the bottom left of the B bubble. And they've got these fancy little diagrams showing I've never understood these, but I'm not a geneticist or cell biologist, and to show sort of the homology and between them and heterology, I guess, between the different strains. And the bottom line is, though, they took another 4 primary MenB strains with different antigens, and then they took an additional MenB strains, and they basically did that randomly so that there was no bias involved. And they showed that if you had immunogenicity against the ones in the vaccine, you actually, basically with the lipidated FHB, it was close enough that you had HSBA, in other words, human serum bactericidal activity generated against all of the strains that expressed factor H binding protein. So there are some meningococcal that just don't express it on the surface, but if it's one of the ones that expresses any of these FHBP strains or isolates, it will basically have activity against them. And through studies, they've shown that about 91% of the Canadian isolates express factor H binding protein at levels that predicted to be susceptible to MenB. And it definitely does, however, vary between regions. And Julie Bettinger just did a study on this. And it was interesting because certainly, I think in Quebec, for example, 100% of the strains produced expressed an adequate amount of FHBP, whereas in British Columbia, it was only 44%. However, it was a huge confidence interval because there were so few strains in British Columbia used. Basically, two-dose study, good number of people had like 73/4 basically showed a good response, and actually a very good response because they actually used a 1 in 8 HSBA, whereas 1 in 4 is felt to be protective. When it says that not evaluate through real world experiences, the problem is with all of these things, none of the meningococcal vaccines, because it's rare, have been shown to work by saying, well, we're going to vaccinate this population and not vaccinate this population. Certainly with Bexsero, as I'll show, there's been a lot of use in national immunization programs. But Trememba has not been used that way because it's not an infant vaccine. And maybe I didn't, I'll show you a comparison slide soon. Again, 2 doses. The second dose is 6 months apart, except for those at increased risk of invasive disease. And again, it can be co-administered with other vaccines. Again, what this shows is it has excellent immunogenicity after strain completion, and the immunogenicity wanes as it does with Bexsero. And so basically, you've got the 4C MenB on the right, or Bexsero, 2 months to 25 years. Trememba on the left, 10 through 25. Trememba has the lipidated FHBP, and 4C MenB or Bexsero has 3 different antigens and the pore A. So, and again, sorry, I'm getting, you need to let me know if you're not seeing the same slides, because I realized that it didn't seem to be going through to you guys. So that's, as I say, 6 months apart for the 2 doses, unless you're at high risk, 1 month apart. Here's the, to the various antigens showing close to 100% immunogenicity compared to the black, which is control, and a waning immunogenicity, though it's boostable. And I should say that both Bexsero and Trememba are very similar this way. Probably the immunity lasts 3, 4, 5 years, but very boostable. And again, the 10 through 25 for the Trememba, the 2 months through 25 for Bexsero, and the different. Okay. So again, just to emphasize, with a MenC vaccine, all MenC is covered. With Bexsero, basically, conservatively, 74% of strains will be covered. In reality, that's probably very conservative, and I'm not going to go into how we came up with these numbers. They're different assays, and because again, it's very hard to test every single strain against the vaccine. Trememba, 91% of MenB strains in Canada express FHBP, though regionally there are significant differences. I'm just going to go very quickly, outbreak control. This is Quebec. This is a specific region of Quebec called Saguenay-Lac-Saint-Jean. I hope you all like my French accent. And it was, there you had an annual incident rate from 2006 to 2013 in this specific region of 3.4 per 100,000. They started using Bexsero in a mass campaign. They vaccinated 82% of the 59,000 people in the region. And essentially, 96% reduction in disease incidence. So very successful. There have been all sorts of university outbreaks, and in vaccinated students, none of them had disease, and they definitely seem to control the outbreak. So it has been used in outbreak control. What I find really interesting is the use in national immunization programs. And I'm just going to go into the concept of vaccine impact versus effectiveness. Effectiveness is really easy. That's how effective. If I vaccinate 10 people, how many are going to be protected? Impact is essentially what's saying is if you have a population of 100 people who could be vaccinated, how many, what's the reduction? So regardless of vaccine status. So that's really simple in a sense. If you got a population of 100 people and none of them get vaccinated, well, it's not going to have very much impact. If 100% of them get vaccinated, then the impact is going to be the same as the effectiveness. So obviously, in terms of the program to have impact, you need to have people vaccinated. At the moment, these are the, as of June, these are the national programs. And in the UK, that's, I think, probably the biggest program, and the earliest started in August 2015. So it's been going on for 5 years now. Andorra is obviously a smaller country, Ireland, Italy, San Marino, pretty small. And then there's regional programs such as in South Australia and in parts of Spain. And basically the UK one, I'm just going to spend a little more time talking about. It was introduced in September 2015. They use a 2+1 vaccination, and you can see it's very high uptake, like incredible uptake for a program. Our routine vaccines in Canada aren't at that level, unfortunately. And you can see that there's significant vaccine effectiveness. And again, these are somewhat estimated. It's hard, obviously, and they're fairly wide confidence intervals. This data is from a couple of years ago. Hopefully we'll have recent data soon, but certainly after the booster dose, even with the confidence intervals, you can see it's 80 to 97% effective. So that's pretty impressive. And there's estimates in 2018 that basically they presented probably in those 3 years, 300 cases of meningitis in that cohort, and sustained protection for at least a couple of years, and 3 million doses administered, and virtually no significant side effects. And I should say also, in Cuba, the outer membrane vesicle, they had 55 million doses administered with very minimal serious side effects. And currently, Bexsero is probably up to, I think it's up to about 50 million doses, but Brian, I think from GSK who's on the line could certainly correct me if I'm wrong, but I believe it's up to about 50 million doses now. So these are definitely safe. And again, this is just in the first 20 months of the UK experience. 1,000 adverse reactions reported, and not many significant ones, no significant safety signals, very high compliance. So these are a couple of questions I have. And first of all, just to make a quick note, Trememba and Bexsero not interchangeable. And that makes sense. I mean, most vaccines, you have one product and you switch to another, whatever, they're pretty similar. But if you basically use Bexsero, well, you're not going to boost it if you use Trememba because it doesn't have the NADA, it doesn't have the NHBA. Similarly with Trememba, the Bexsero doesn't have the lipidated FHBP. So they're not interchangeable. You have to finish the course with the same product and boost with the same product. In terms of impact on carriage, if you recall, when I showed you that UK slide, MenC basically went down to 0. It didn't just go down to 0 in the cohort that was vaccinated. Previously, they had it all across the age range. It went down to 0, period. You just basically eliminated meningc. And that's because you were nobody was carrying it anymore. And you got significant herd immunity. And unfortunately, probably, I mean, there's some conflicting information on this, but most of the information suggests that there's very little impact on carriage for these vaccines, which means there's going to be very little effect on herd immunity, which is a shame. I believe there's an ongoing study that's looking at this with Trumemba and Bexsero that probably will be out in the near future, but unfortunately, I suspect that probably won't show much. In terms of immunity, at least 3 years, probably longer than that, and probably at least 4 or 5. Booster dose is likely effective after years. The other thing that I find really interesting is this idea, well, hey, this is no longer using the polysaccharide of the B vaccine. It's using things that are expressed on other Neisseria meningitidis. Is it going to be protective with other serogroups? And probably it is. Again, we don't have clinical studies showing this, but we have studies that have compared like serum bactericidal titers against all sorts of strains in various parts of the world. And certainly pretty good evidence is suggesting that Bexsero probably cross-protects against C, W, and Y at least. And the A isn't there probably only because they didn't have any A serotypes isolated in the populations they used to find the bacteria. And maybe about 70% of individuals who were vaccinated had protection against the C, W, and Y. And Trumemba also, there's some evidence suggesting it also probably protects about C, W, and Y. Somewhere between 50 and 100% of individuals seem to develop antibodies, and even perhaps A, and it's about a quarter of individuals vaccinated in this one study had protection against A. So there probably is some cross protection. The other thing that's really interesting is what about other Neisseria? Well, in fact, with Bexsero, in the Saguenay-Lac-Saint-Jean outbreak in Quebec, the incidence of gonorrhea went down quite substantially in the cohort that was vaccinated. And that was despite an increase in that time. So this is from beforehand to after the outbreak or the vaccination program. The incidence of gonorrhea in the vaccinated cohort decreased substantially, whereas the incidence of chlamydia went up. And in the older cohort, in other words, the non-vaccinated one, the incidence of gonorrhea went up. So that was kind of interesting. And certainly, you know, if you get a decrease of half or 50, 60% of gonorrhea with this vaccine, that could have substantial impact on the epidemiology. So I'm just going to talk briefly. There's basically there's fair evidence to recommend this use during outbreaks, and that would be off-label as well. If there's an outbreak, or if you're exposed in the emergency room, or exposed, you know, if you're going to travel or going to join the military and be in barracks, you'd probably want to use this off-label, even older than 25. And so just to say that briefly, I'm just going to fly through some of these slides. This isn't a publicly funded vaccine. Parents probably are unaware, and it's something I think it's probably reasonable to inform them of, even though this is a rare disease. Because the bottom line is what you don't want to do is, you know, it's essentially that we didn't know. You know, it's, you know, after the fact, it just takes one of these, unfortunately, and, you know, parents go, why did I not know? Of course, if I knew about this, I would have had my kid immunized. They might have, they might not have, but certainly everybody would have wished they'd known at that point in time. And I think it is reasonable. Different people have different priorities and feel strongly about different things. And I think it's something that should wear basically, you know, recognize that especially for children less than a year, this is fairly, I mean, it's still rare, but it's significantly more common than older population. And it can be given again with the routine vaccinations, but it is not covered. And again, parents have different priorities, and a lot of people, this may be something that they want to put their money into, and it is not covered by, you know, it's not covered by our public program at the moment. unless actually you're immune compromised in certain, like splenectomy or asplenia. Basically, I found this slide really interesting, just the sort of standard approach versus a presumptive approach on the right. In other words, what do you plan to do about your daughter's influenza vaccine versus your daughter's due for vaccine? Should I give it today? And let's review different vaccine options. Your daughter is a candidate for MenB. Is it something that you want to do, type of thing? So I think that a presumptive approach is pretty reasonable. And I'm not going to go through these case studies. I'd rather take answers. So I think it's really important to counsel people about the availability. On the other hand, I don't believe in terrorizing them or making them feel, significantly, absolutely worried about this, and that's all they're going to think about. So, I mean, you have to put things in perspective. This is a serious disease. It happens in healthy individuals. It unfortunately does have very significant mortality and morbidity. And, but at the same time, fortunately, it is rare. So I think at that point in time, just looking at the time, I should open it up for questions. Unless you want me to keep on talking, because I can talk for hours, as most of my colleagues know.
Why do you ask a question?
Jane, go ahead.
Okay, I'll ask a question. Oh, a comment. Oh, thank you so much. It was very, very thorough, and I learned quite a bit. I think we should know that this vaccine, the B vaccines, are not covered in BC at all unless you're in an outbreak with a known B case. So even for children who have had splenectomies or are on Soliris, which is a MAB that targets terminal complement components, putting these kids at incredible risk for MenB disease, it's not covered.
Yeah, you are right. I misspoke there, Jane.
Yeah,
so it's provided free
very
to
annoying.
those contacts of serogroup B, and 2 years if there's an outbreak or in the hyperendemic strain. But the BCIC recommends it for medically high-risk individuals, but they don't provide it free.
Louise McKenzie asks, what are the costs?
So I don't know. I think it's about $100 a dose. That's my understanding.
If anyone has the answer, they can put it in the chat box as well.
Some
Jane,
people have coverage through their insurance.
Jane, do you administer it in your office?
Well, I have, but mainly through the family immunization clinic. So we sell it at the pharmacy across the hall, and it's about $150 a dose. Some people have coverage if they have extended medical, depends upon their plan.
Any other questions?
I don't need to dominate, but I have another question.
Sure.
So, okay, here's, we've got a teenager and she's on some immunosuppressive, or maybe she's got HIV. Which one of these vaccines would you recommend? If you could, choose either one in BC.
That's putting me on the spot.
Yeah, well,
Probably.
I know I've asked Julie Bettinger and she won't say, but.
Why do you want me to say? If you
well, because you did this talk and you read all about it, so.
It's a hard one. I think, it's really a hard one. I think I would probably pick Bexsero. But I mean, I think they're both excellent vaccines. It's a hard one. I mean, the thing, I mean, Julie did the data, so she's the one who should comment, but Bexsero, probably covers 3/4, probably conservatively, maybe more. If I was in Quebec, I probably would pick Trumemba, but either both. And the other thing, teenager, I mean, I like the idea of the Bexsero covering other Neisseria like gonorrhea, but I think either one would be. I think they're both excellent vaccines.
Thanks.
Yeah, it'd be easier if you asked me a 9-year-old.
Yeah.
Do we have any other questions for Bill? I found this very interesting, Bill. I've never
Hello?
shared this before, but as a toddler, I had meningitis. So learning as an adult is quite interesting. Jana, you have your hand up. Question.
I do. So, Bill, we practice in the same community, and I do all the children's vaccinations for flu in my office. So, we're starting on the 20th. So, specifically, what do I say to these parents? Because now I have them coming in for the flu vaccine. What do I recommend specifically? And what do I say? So, for these different age groups, should I just be hitting up on my little kids and then my somewhat older kids? And there's the problem of the booster. So when do you do that? So what exactly do I say to the parents?
I think you just give them the data, basically. I mean, one way to do it, I think, first of all, I think in terms of, especially now with COVID, and especially because I think really flu is so important right at the moment, and it's hard enough to get this in, you do the counseling via telehealth in terms of, give them sort of, just let them know what options are out there in terms of vaccines, especially for infants, with respect to Bexsero and its infant indication, that it, can be given with routine shots, and which is and basically kids under a year are higher risk, and so if they want to do that at the same time, recognize with Bexsero just the timing. So the flu shot. I mean, with younger kids, obviously you need a second flu shot as well, so that makes it easier. It can be given, I'm pretty sure Bexsero can be given with the flu shot. Has it been tested with that? I shouldn't just glibly say. I mean, there's no reason that it shouldn't. Let me just double check. Because
I mean, first of all, you give Bexsero at 2 months and you give the flu shot at 6. But if you're giving the first flu shots at 6 months, you're going to see them 4 weeks later. So that's my golden opportunity to say, hey, do you want to fork out for this other vaccine? I'll give your baby both. So can I do that?
So can you give it at the same visit? So technically, as far as I'm aware, it's not one of the vaccines that has been given with Bexsero. In other words, the testing hasn't been given. The infant vaccines have. Brian, do you mind, Brian T, do you mind commenting on this? Do you have any information?
Yeah.
With influenza?
So, hi, for those of you who don't know, I'm the medical science liaison with GSK, formerly with the vaccines team. So you're correct, this hasn't been studied in an infant population co-administered with the flu vaccine. Unfortunately, when you look at a lot of the vaccine studies, a lot of the combinations are not actually studied just because it's too complex to do in the context of a clinical trial. And so the best thing to do is to fall back on the Canadian immunization guidelines, which is based off of a review of evidence as well as expert opinion. And it's said in that guideline that any non-live vaccine can be administered with any other vaccine at the same visit, recognizing that ideally you would have a 1-inch spacing between those immunizations if in the same limb. So that is the national guidance from the Canadian immunization guidelines in terms of co-administration of vaccines.
So is there any problem then if you're going to tell them to take them acetaminophen? If you're giving, say you give one in each leg, right? They're 6 months old, or one in each arm. And then what about this business of giving them acetaminophen? Is that in any way not a good plan when you're giving the flu vaccine, or does it matter?
No, that's not a problem.
Okay. And so then the other group of kids are these older kids, right? And I have lots of, diabetics. I have lots of kids who this year especially are going to come and get their shots because suddenly everyone's interested. So this is my golden opportunity. Is there any, we're not allowed to have brochures out and about anymore, but is there any way to get some info to me so that at the first visit I can hand the info out, and then those parents can pick up on it when they come for their next visit. Because
So
patients like
on-
to have something to look at, right? They need a brochure, like Twinrix has, you know, information and dosage schedules and stuff. Is there somewhere that I can access some of this info? Because people do need handouts. And I'm a GP, I'm not a pediatrician.
So on the call with me today, I also have my colleague, Flora Wong. Sorry, Flora, I might have butchered. No, yeah. She's our sales representative, and she will be able to comment on the availability of materials.
Yeah, hi. I can definitely reach out to you this week and get your address and have some stuff sent over to you.
Sure, that would be great, because I can't display it, but I can hand it out to individuals. And this is like the opportunity, right? These vaccines are coming up. People have to book it. As you say, over telehealth, or when you're doing your well baby checks and stuff, you're talking to patients, and it is a good opportunity to offer it, right? Same as, you know, when the rotavirus vaccine came out, it wasn't a routine vaccine, but lots of patients picked up on it if you brought it to their attention. But you have to have something to give them to look at afterwards, right? To
Jane Finlay here. We have a material on the BC Pediatric Society. There's handouts for meningococcal B vaccines.
okay.
And I would recommend that we start talking about it at the on or before the 2-month visit, because
Right.
The highest number of cases in the little babies is actually under 6 months.
Okay,
So
because
it's good to get it in early.
right. Well, I don't deliver anymore, but I'm still
Yeah.
seeing my babies by and large no later than 6 weeks if it's a midwife delivery, and much earlier if it isn't. So it is an opportunity. So should I can just print these off the BC Pediatric website,
Yep.
right?
Mhm.
Okay, thanks.
Awesome. Well, I hope you enjoyed it, and hope you learned something. I always learn something at these with all the questions that I can't answer, so I quite enjoy it. Yeah, if there are any more questions, happy to take them. And everybody probably knows how to get in touch with me. Anyway. So if there are questions afterwards, please let me know.
Thank you, Bill. And
Thanks, Bill.
Jenna, Chris in the chat room has listed the exact website address that you can find that information. You beat me to it, Chris. Thank you.
Well, we'll see if I can figure out the chat room. I'm not good. I'm new at Zoom, but I'm trying. So there we go.
That's fine. Jana, at the bottom of your screen, there'll be a button that says chat. It looks like a little bubble, a thought bubble. If you click on it, it will open up the chat and you will see a link for the meningitis. If not, you can always follow up with the society later and we'll help you.
Sure. Or I can just hit up on Bill, who lives in my community.
I can get that. I mean, I was actually, in my previous talks, I used to show the BCP's pages, because there's some quite nice ones about, non-publicly funded vaccines and how to get them, because it can be a bit of a rigmarole. But the last couple of times I've gone there, I've intermittently had problems with the links. And I think the website's going to be brought up to date in the near future, I'm hoping.
Okay.
We just have to
Thanks.
find the resources. It looks like the questions have slowed. And so I'd like to take this opportunity, Bill, to thank you so much for sharing your time today, and thanking our sponsor as well. Please look in the chat box and click on the SurveyMonkey feedback form. This is a way that will reduce a lot of effort in faxing feedback forms back, and it's instantly updated in our system. This will be really helpful for Bill and for the society as we build out future CME events. Thank you very much for coming, and thank you, Bill.
Thank you.
Thank you, guys.
Thanks, Bill. Great session.
Okay, take care. Bye, guys.
Bye-bye.